Good morning, ladies and gentlemen. The topic of today's lecture is Pityriasis Rubra Pilaris. Introduction. Pityriasis Rubra Pilaris, abbreviated as PRP, initially presents with erythematous, hyperkeratotic, perifollicular papules. Erythematous, hyperkeratotic, perifollicular papules which tend to coalesce into plaques but may progress to erythroderma, particularly in adults. So the primary lesion is a papillosquamous rash, primarily erythematous, with perifollicular hyperkeratosis. They becomes the papules coalesce to form plaques, and plaques coalesce to form erythroderma. The distribution, age of onset, and speed of onset differ markedly in different types of PRP, and these differences help in classifying PRP into different clinical subtypes. PRP is a papillosquamous disorder of unknown etiology, and it was traditionally divided into 5 clinical subtypes by Griffith, but the 6th type was introduced after HIV infection. So now there are 6 clinical subtypes of PRP. Incidence and prevalence. PRP occur in less than 1 in 5,000 individuals in UK. The rare familial form of PRP starts in early childhood, while in rest of the cases, PRP has a bimodal age distribution. That is, it has a peak in the first decade, and then there is another peak in 5th decade. It has equal sex incidence, and there is no racial predilection. Associated disease. PRP is not generally thought to be associated with any underlying malignancy, and it is described in association with systemic sclerosis and autoimmune thyroiditis. Pathophysiology. As I've stated before, the pathogenesis of PRP is mainly unknown. A rare familial or genetic form is linked to a functional mutation in CARD14 gene. Such mutations are rare in sporadic form of the disease. Then there is a theory that streptococcal supraantigens are implicated in children with a sporadic form of PRP. Then PRP is associated with HIV. That's why the 6th clinical subtype is introduced, which is PRP with HIV infection. Pathology. As the pathogenesis of PRP was not clear, histopathology of PRP is not very specific and not pathognomic. The findings are there is hyperkeratosis with follicular plugging, and then the ortho and parakeratosis alternates both vertically as well as horizontally, with parakeratosis in the perifollicular shoulders. There is confluent hyperplasia of epidermis, almost like psoriasis. And there is sparse lymphocytic dermal infiltrate with no neutrophils. So there are a few differences between psoriasis and PRP. The first is that in psoriasis, there is confluent parakeratosis. That is, parakeratosis is seen from one end to the other end of the biopsy specimen. While in PRP, the columns of parakeratosis alternate with columns of hyperkeratosis. And usually this alteration is seen both horizontally, like I am moving my cursor, as well as vertically. That is, in the top, there will be hyperkeratosis, then a parakeratotic column, then again hyperkeratosis. So both horizontal and vertically, there is alternating hyper and parakeratosis. Then but in this case, there are no Monroe abscesses, which is the feature of psoriasis. And the epidermis shows uniform psoriasiform hyperplasia, just like psoriasis, but there are no spongiform pustules of Kogoch. And lastly, in psoriasis, the vessels are tortuous and there is a moderately dense perivascular infiltrate, while this infiltrate is quite mild in case of PRP. This picture shows the follicular plugging, which is not seen in psoriasis. Then this image shows alternating these are para and hyperkeratosis in vertical plane. And underlying epidermis shows hypergranulosis, which is usually absent in psoriasis. There are three conditions in which there is alternating hyper and parakeratosis. One of these is PRP, then inflammatory linear verrucous epidermal nevus, and actinic keratosis. Clinical features. The more common generalized sporadic forms, which are type 1 and type 3, tend to have an acute onset. Then a rare familial form of PRP, which is type 5, generally has a slow and gradual onset. Patients typically present with well-defined salmon red or orange red, dry scaly plaques, which may coalesce to become widespread. So one of the features of PRP, which is different from psoriasis, is its rapid onset. Another feature, which is again different from psoriasis, is that these lesions, they frequently become erythrodermic and rapidly become erythrodermic. Typical islands of normal skin are present between these erythematous papillosquamous lesions, and these islands of normal skin are called as islands of sparing. This is typical of PRP, which is not seen in psoriasis. Disease often starts on scalp. Some patients become erythrodermic, especially the sporadic forms. Pruritus may be present in early stages, but later stages it is usually absent. And here, there is a characteristic hyperkeratotic plaque with erythema, and at the edges you can see follicular hyperkeratosis, follicular lesions with hyperkeratosis. You can in the center, this is a plaque which is mainly found by the coalescing of the individual hyperkeratotic erythematous follicular lesions, but at the periphery, discrete follicular hyperkeratosis is seen. So this is a clue to differentiate this kind of psoriasiform lesion from psoriasis, because psoriasis, you can see this color of lesion with scales, but you will not be seeing these follicular hyperkeratotic lesions. On elbow, wrist, and back of the fingers, characteristic follicular hyperkeratosis is present, which is also called as the nutmeg greater papules. Palm and soles become thicker and fissured, just like psoriasis, but the hyperkeratosis in PRP is slightly more than that which is seen in psoriasis. In type 4 PRP, the disease is mainly limited to the extremities, the atypical form. Then we will discuss one by one the 6 clinical subtypes of PRP. Type 1 is the classical adult onset PRP. This is the most common form, and it represents 50% of all cases of PRP. Sexes are equally affected, and highest incidence of the disease occurrence is in ages of 40 to 60 years. Eruption usually start as erythematous, slightly scaly macule on head, neck, and upper trunk. True diagnosis become apparent with appearance of erythematous perifollicular papules, which I have already highlighted. The follicular lesions are initially discrete, but then coalesce to form groups of 2, 3, or more papules and ultimately forming plaques. You can see the whole body in both these cases are involved with islands of sparing, which is quite typical of PRP. Interfollicular erythema and follicular lesions are gradually submerged in sheets of erythema, which typically spread from head to toe. This prolonged erythema may give rise to peripheral edema in elderly and may precipitate high output cardiac failure. Scalp show diffuse bran-like scaling. Erythroderma frequently develops within 2 to 3 months. Sharply demarcated islands of unaffected skin remain as a helpful diagnostic sign. These are called as islands of sparing. You can see the evolution of type 1 PRP over 4 months from just inflamed limited lesions to diffuse erythema. Limited lesions to diffuse erythema. So the evolution from a limited disease to whole body disease is quite rapid, and it occurs within few months, which is not a feature of psoriasis. Palm and soles become hyperkeratotic and yellow. Nails are thickened and discolored distally with splinter hemorrhages. So the main findings in nail is hyperkeratosis, but usually there is no pitting. Untreated type 1 does eventually resolve in an average duration of 3 years in majority of affected patients. So like psoriasis, is not a permanent condition. You can see the phase involvement, then palm and soles. There is diffuse hyperkeratosis of palms, keratoderma, which have a yellowish color. Then you can see thick hyperkeratotic nails with some splinter hemorrhages. Type 2 PRP is atypical adult onset PRP. This kind of PRP has a chronic course and may last for years. And the scaling is rather variable. Although perifollicular scales are seen at places, but they may be absent. Then palmoplantar keratodermas is a feature. Then rapid progression does not occur, and erythroderma is less common in this atypical adult form of PRP, which is PRP type 2. Then PRP type 3 is the classical juvenile onset PRP. Type 3 is most common type of PRP in children and is considered to be a counterpart of PRP type 1 in adults. But the onset of this kind of PRP is from 5 to 10 years of age. This form of PRP undergoes spontaneous resolution in 1 to 2 years, while adult onset PRP resolves in 3 years. Some patients evolve into type 4 PRP and vice versa, which is a limited type, and so after diffuse type converted into a limited type. Recurrence of type 3 PRP in older adult type is also reported. So a child may develop a PRP in 5 to 10 years of age, then he becomes all right and again develops similar kind of PRP in later years of age. Type 4 is the circumscribed juvenile type of PRP. This is seen in 25% of PRP cases, and it occurs in prepubertal children. It is characterized by well-circumscribed plaques of erythema with follicular hyperkeratosis, as you can see here, occurring mainly on the elbow and knees. So this follicular hyperkeratosis differentiates these plaques from the psoriasiform plaques or psoriasis plaques. Palmoplantar keratoderma may be observed. There are reports of the disease remitting in teen ages. These are all images of circumscribed lesions of PRP. This the plantar keratoderma is quite obvious with orangish, yellowish hue in this case. Then the fifth type of PRP is the atypical juvenile type. This is a chronic childhood type that accounts to only 5% of the cases. And the familial PRP is most often of this type, and it is difficult to distinguish it from ichthysis and erythrokeratodermas. Type 5 PRP may be present at birth if it is familial or start in early childhood with erythema and hyperkeratosis. Follicular hyperkeratosis is a prominent feature and is diagnostic from the other similar conditions like erythrokeratoderma. And palmoplantar keratoderma is also common. Then the type 6 PRP, which is HIV-associated PRP. This form of PRP became apparent with the onset of HIV epidemic. This resembles type 1 PRP, but is resistant to treatment. And it is, however, responding to antiretroviral therapy. A spontaneous remission without treatment is possible once the viral load reduces. Some patients develop elongated filiform keratosis on the face and the trunk. Differential diagnosis. All the dermatosis with erythema and follicular hyperkeratosis should be considered in the differential diagnosis. And this differential diagnosis, the first and foremost is psoriasis, then erythrokeratoderma. Then once there is diffuse erythroderma, then Sézary syndrome and other T lymphomas also come in the differential diagnosis. And type 4 PRP resembles keratosis circumscripta, but difference between keratosis circumscripta and circumscribed PRP is erythema. So erythema is present in PRP, but in keratosis circumscripta, there are only plaques of follicular keratosis, but no surrounding erythema. Complications and comorbidities. The dependent edema and high output cardiac failure is seen in erythrodermic patients. Disease course and prognosis. Classical type 1 PRP progress from limited disease to erythroderma very rapidly within few months, matter of weeks, and eventually it clears. Maximum time to clear is 3 years. A spontaneous resolution as long as after 20 years is reported in some patients. And there are few patients who persist indefinitely. The classical juvenile type of PRP, which is type 3, runs again a short course with remission by 1 year of age, after 1 year. Then atypical PRP, which is type 2 and which is atypical adult type, and type 5, which is atypical juvenile type, are both chronic diseases, but usually remain limited and never becomes erythrodermic. The prognosis of circumscribed juvenile PRP, which is type 4, is uncertain, and it lasts indefinitely. This slide shows a few significant differences between PRP and psoriasis, because these are the two diseases which are quite similar to each other. So as far as the scalp scaling is concerned, PRP will have a furfuraceous scale, easily removable scales, but psoriasis have thick adherent scales. Then palmoplantar keratoderma is much more common in PRP as compared to psoriasis. Then islands of sparing is a characteristic feature of PRP, but it is not seen in psoriasis. The nail pitting and salmon patch in nails is absent in PRP, but present in psoriasis. Nail growth rate. It is moderately increased in PRP and markedly increased in psoriasis. Epidermal cell turnover, which is a main feature of psoriasis, it is markedly increased in PRP, it is moderately increased. Then Monroe microabscesses are seen in psoriasis, not seen in PRP. Seronegative arthropathy is seen in psoriasis, and PRP is not associated with arthropathy. UVB phototherapy, psoriasis has a good response, PRP does not have a good response. Topical corticosteroids, psoriasis has a good response, PRP does not have a good response. Methotrexate, psoriasis has a good response, PRP does not have a good response, rather a variable response. Then tumor necrotic factor alpha blockade, good response in psoriasis, but variable response in PRP. The only treatment which has an excellent response is interleukin-12 or interleukin-23 blockades. And psoriasis also have a good response with this therapy. The last part is management. PRP is not a common disease, it's a rare condition. And the recommendations of treatment are mainly based on case reports because there are no large-scale studies since the disease is not very common. And the other source of treatment is the retrospective studies. Patients who are arthrodemic may need intensive supportive care to prevent hypothermia, electrolyte imbalances, protein loss, and sepsis. Review of 40 patients with PRP, 14 show marked spontaneous clinical improvement. Only 3 patients appear to benefit from various types of phototherapy. So usually phototherapy is not very effective. Then 19 patients receive acitretin, along with whom 5 showed marked and 5 show partial response. 3 patients reported to have marked response to methotrexate. So both these 2 treatments, rather 3 treatments of phototherapy, acitretin, and methotrexate has excellent response in psoriasis, but the response is not good in PRP. In a systemic review of response of PRP to type 1, PRP type 1 to tumor necrotic factor antagonists, the authors felt able to attribute either complete or partial response to infliximab, adalimumab, and etanercept. There are several case reports of dramatic response to anti-interleukin 12 and interleukin 12 antibodies, which is ustekinumab. So ustekinumab is the only treatment which has stood out from all the other treatment in the management of PRP. Emollients should be applied liberally and form an important part of management for treating dry skin and restoring the barrier functions in all patients of PRP. Topical corticosteroids prove symptomatic relief, especially if patients are having pruritus, but do not have any long-term influence on PRP. Then topical calcipotriol and topical tazarotene are both advocated in the circumscribed type of PRP, but evidence of efficacy is small, and it is not as effective as in chronic plaque psoriasis. So whenever the systemic therapy is warranted, acitretin in a dose of 50 milligram per kg is a better choice of systemic treatment than the other modalities of treatment. Methotrexate in dose up to 20 milligram once a week may be considered, sometimes combined with acitretin. Then ustekinumab is proved to be more effective than other agents in managing PRP. So lastly, we are going to highlight the treatment ladder. The first line treatment is emollients, then the topical corticosteroids and acitretin. So these 3 should be kept as a first line. Then if not effective, then second line treatment include topical calcipotriol and tazarotene, especially in circumscribed variety, then methotrexate and ustekinumab. Then third line treatment include tumor necrotic factor alpha antagonist, UVB phototherapy, and extracorporeal photochemotherapy. So this brings to the end of this lecture. I thank you all for patient listening, and goodbye and have a good day, and hope to see you next time with another edition of my lecture.